Land. Happy to have everybody. Happy to be recorded this morning. This is our first grand round session, so very exciting. We're glad to have Dr. Mike McDermott, who's a professor of medicine in the division of endocrinology. Went to med school at Tulane and did all of his training in medicine and endocrinology here at the Fitzsimmons Army Medical Center. He's an outstanding clinician and teacher, and this is a topic that I was just telling him I can't get enough of. I think that it's so interesting and something that general internists are well poised to manage in our clinics. And so Dr. McDermott's going to take us through this topic, and hope you all enjoy it.
Thanks, Brandon. Appreciate it. Everybody here okay? All right. So the most common endocrine disorder that we see is hypothyroidism. That occurs actually in 1 out of every 10 or 12 people, so it's very common. But hyperthyroidism is not quite as common, but about 1 out of every 100 people get hyperthyroidism. So it's a timely topic, and things are changing the way we manage it and the way we diagnose it. So I don't have any conflict to disclose, and here's the objectives today. I'm going to go over the diagnostic tests. How do you really make the correct diagnosis? Discuss the clinical significance of overt versus subclinical thyrotoxicosis, and then go over the management. How do you approach somebody? I think that's what I'm going to spend most of the time on. So let's see, how do I get rid of that banner up at the top? There we go. All right. So everybody knows you start an endocrine lecture with physiology. So the hypothalamus actually regulates the whole thyroid axis by making thyrotropin releasing hormone, which stimulates the pituitary gland to make thyroid stimulating hormone, TSH. That stimulates the pituitary gland to produce a whole lot of T4 and a little bit of T3. And most of the T3 in the body actually comes from peripheral tissues like the liver. And then T3 predominantly feeds back at the hypothalamus and the pituitary to say, yes, we do have enough thyroid hormone, or we don't, make some more TSH or not. And that's why TSH then is our best. It's not a perfect test, but it's our best test for diagnosing disorders of thyroid function. So when we're screening or case finding, screening is just testing people at their annual visit. Case finding is because they have symptoms. The best test overall to start with is a TSH. Not perfect, but it is a very good place to start. Now, if the TSH is low, you very likely have thyrotoxicosis. You want to measure both a free T4 and either a total or free T3. And the reason we do both of those is because sometimes people with thyrotoxicosis only produce T3. It's called T3 toxicosis, and you can miss that if you only measure a T4. So you want to measure both if the TSH is low. Now, we're not talking about hypothyroidism today, but if the TSH is high, of course, you have hypothyroidism. You don't need to measure a T3 in hypothyroidism because it's almost always normal. The body sort of preserves T3 until the very end. So you really only need to measure a free T4. So the first thing you want to do when you've diagnosed thyrotoxicosis is determine the severity. So if the TSH is low, you've now measured your T4 and your T3. If one or both of those is elevated, we call that overt thyrotoxicosis. And overt thyrotoxicosis really always needs to be treated. They always need to have some sort of management. If the T3 and the T4 are within the reference range, I put normal here, but I mean in the reference range. You know, there's a wide reference range. And so we'll talk about what this means, but this is called subclinical thyrotoxicosis. Okay. So let's start with the first case. It's a 28-year-old woman who has a 4-month history of fatigue, palpitations, and heat intolerance. She has some systolic hypertension and tachycardia. Both of those are characteristic of thyrotoxicosis. Hyperthyroidism raises your systolic blood pressure. Hypothyroidism raises your diastolic blood pressure. And her body weight is a bit low for 5'6". Her thyroid is diffusely enlarged, 2 times normal. Her serum TSH was screened and it was undetectable. Reflexively, they measured a free T4 and a total T3. Those were significantly elevated. So she's got overt thyrotoxicosis. So what's the very best test now for us to get a correct diagnosis? A radioactive iodine uptake in a scan, or a thyroid ultrasound, or a thyrotropin receptor antibody, or a thyroperoxidase antibody. So the answer here, of course, and you all do this very well, is measure a thyrotropin receptor antibody. This is the actor. This is what causes Graves' disease. This is an autoimmune disease. This is the antibody that stimulates the thyroid gland. If it's positive, they have Graves' disease. If it's negative, they have something else, and you need to look farther. So after determining the severity, your next goal is to determine the cause. So hyperthyroidism actually is a specific term within the subgroup thyrotoxicosis. It refers to Graves' disease, toxic multinodular goiter, or toxic nodules. These are all disorders where the thyroid gland is taking up iodine, is making thyroid hormone, and is secreting too much thyroid hormone. So that's called hyperthyroidism. Everybody calls everything hyperthyroidism, and that's fine. But if you talk to some pure thyroidologists, these are the only conditions that actually are called hyperthyroidism because the gland is hyperactive. Whereas thyrotoxicosis of other causes like thyroiditis, where the gland is inflamed and spilling out thyroid hormone, is thyrotoxicosis, but not hyperthyroidism, okay? Thyroiditis comes in 3 flavors. There's a postpartum thyroiditis that occurs after pregnancy, silent thyroiditis, which is identical, but it's not after pregnancy, and then subacute thyroiditis, which is a painful disorder that's often associated with fever and a very high SED rate. We have amiodarone-induced thyrotoxicosis, which is actually fairly common. Iodine-induced thyrotoxicosis that occurs after iodine contrast media are given for CT scans, or somebody's given SSKI, maybe for an infection of some type, and factitious use. And we don't think about this all that much. We don't think that people might be purposely or even accidentally taking thyroid hormone, but you'd be surprised how many supplements over the counter actually have thyroid hormone, or, although it's not this, have adrenal extracts. People are actually taking steroids and they don't know about it. But people take T4 and T3 unbeknownst to them sometimes in their supplements. So to get to the cause, we start with a physical exam, and there's probably no area of endocrinology where a physical exam is more valuable than in determining the cause of thyrotoxicosis. Because there's certain signs that are specific for Graves' disease itself, and that's a diffuse goiter. Nothing else has a diffuse vascular goiter. The orbitopathy, where people have proptosis and periorbital edema and chemosis, and pretibial myxedema, these are signs that only occur in Graves' disease. So if you have a person that has these, they have Graves' disease. Okay, you don't even really need a test after that. So those are signs specifically of Graves' disease. Now, we like to measure thyrotropin receptor antibody, or depending upon where you are, thyroid stimulating immunoglobulins may be available in other labs. And if these are positive, that's Graves' disease. So if you don't have the specific Graves' signs, measure a TRAB. Now, we usually measure TRAB anyway because it's a good marker for us to follow when people go into remission. Their TRABs become negative. So generally we'll get a TRAB, and these are going to be positive. Again, that confirms it's Graves' disease. But if somebody has nodules when you feel their thyroid gland, then instead you need to get a radioactive iodine uptake and scan. That's where the older nuclear medicine studies are important. And if you have a person that doesn't have nodules, but their TRAB is negative and you need to know the cause, that's again where the radioactive iodine uptake and scan is useful for you. If the radioiodine uptake and scan show high uptake or even normal uptake, which is not normal in the face of a low TSH, then it's going to be one of these 3 things: Graves' disease, toxic multinodular goiter, or a toxic nodule. Whereas if the radioactive iodine uptake is low, it's going to be one of those 3 types of thyroiditis. It's going to be amiodarone-induced thyrotoxicosis, exogenous iodine, or factitious use of thyroid hormone. So that's how we diagnose the overall cause. So here we have this, a number of years ago, I went to Ethiopia. They asked to start an endocrine fellowship there because they have a huge amount of two things. They have diabetes and they have a large amount of thyroid disease. And so I went over to help them start a fellowship program. This is one of the patients I saw on the first day. You can look at her thyroid. It's huge and it's diffusely enlarged. And if you feel it, it feels like a sponge. It's very vascular. You can actually squeeze it. It's not firm. It's not nodular. If you listen to it, there's bruise. So this is a highly vascular gland. And you can see also that she's got thyroid eye disease, Graves' orbitopathy. No tests are needed here. She's got Graves' disease. Here's somebody that just has thyroid orbitopathy. Not as much. There is a little bit of proptosis, but you can see the periorbital edema here above the eye and a little bit of chemosis. There's a little bit, which is edema in the conjunctiva. Now, you'll never see one this bad, but this is pretibial myxedema. Myxedema sounds like hypothyroidism, but it's actually a skin infiltrative disorder that occurs on the shins of people who have Graves' disease. So the three extrathyroidal signs of Graves' disease are the orbitopathy and the diffuse goiter, excuse me, let me go back, the diffuse goiter and the pretibial myxedema. So when TRAB is negative, I said you go ahead and order a radioactive iodine uptake and scan. And so what happens when the radioactive iodine uptake is high or normal? As I mentioned, this is going to be what we call hyperthyroidism. It's either Graves' disease, toxic multinodular goiter, or a toxic nodule. Now, why is a normal radioactive iodine uptake listed here? Because these people have thyrotoxicosis. Their TSH is completely suppressed. TSH is the only normal stimulant for the thyroid gland to have any uptake and to work. And so if the TSH is undetectable, then even a completely normal radioactive iodine uptake is not normal. It's inappropriately normal because that person has a suppressed TSH, and that means the thyroid gland has autonomy. We talk to our nuclear medicine people about that sometimes. They'll say, this is a normal scan, this is a normal uptake. And we ask them, well, look at the TSH. If the TSH is undetectable, don't tell the doctor who ordered that this is normal. It's completely abnormal to have normal uptake if your TSH is low. So you have to interpret this in the context of what the TSH is. So if the radioactive iodine uptake is high or inappropriately normal with a low TSH, get a thyroid scan. And that's going to tell you what the disease is. If it's diffuse uptake, that's Graves' disease. If it's patchy and just in places, it's the toxic multinodular goiter. And if it's uptake in only one spot, it's a toxic nodule. So let me just show you some pictures of that. That's a picture of Graves' disease. So we know that Graves' disease is it's an autoimmune disorder caused by the production of TSH receptor antibodies. These are antibodies that bind to the TSH receptor. Every cell in the entire thyroid gland has a TSH receptor. So that's why the uptake is diffuse. And so that's typical of what we see for Graves' disease. On the other hand, this is patchy uptake. You see, this person, if you felt, probably has a nodule here, probably has a nodule here. So this is patchy uptake consistent with a toxic multinodular goiter. It's not important because you can't measure these, but each of these little nodules has developed an activating mutation that makes those cells autonomous so that they're functioning in the absence of TSH. And then solitary uptake. So this is a toxic thyroid nodule that is overproducing thyroid hormone. The TSH is low, so the rest of the gland has suppressed uptake. And this is also due to an activating mutation, making the cells in that autonomous, not responsive to TSH, but overactive constitutively. So now we've diagnosed Graves' disease or toxic multinodular goiter or toxic nodules. So how are we going to treat that? So these again are the ones that we want to treat with a thyroid-specific therapy. And our armamentarium includes anti-thyroid drugs, methimazole and propylthiouracil, radioactive iodine ablation, and thyroidectomy. And all of these actually are reasonable. There's not one that is always preferred. And so I think this is just an ideal situation where shared decision-making is important. I tell people about these treatments. Some people want to be treated with a medication. They don't want anything to do with surgery or radioiodine, but some people actually want to get their disease taken care of now. They want to take radioactive iodine or surgery. They don't want to mess around with meds for 2 years. So this is a good situation for shared decision-making. So what about our antithyroid drugs? In Graves' disease, we use these in hopes of achieving a remission. And a remission will occur in about 50% of people if we put them on an antithyroid medication. The remission is marked by the disappearance of TRAB. So TRAB are positive when you make the diagnosis, and when they go into remission, their TRAB goes away. The other thing that happens is their diffuse goiter resolves. They go back to a normal sized thyroid gland. So we can achieve a remission in 50% of people, and they don't have Graves' disease anymore. There are people who don't achieve a remission but don't want radioiodine or surgery, and so it's reasonable in those people to also use an antithyroid drug in a low dose chronically. Toxic multinodular goiters and toxic nodules are not autoimmune. They're neoplastic, they're benign neoplasms, and they don't ever go away. So remission is not possible with antithyroid medications. So we mainly use these to make a person euthyroid to prepare them for radioactive iodine ablation or a thyroidectomy. However, there are people who say, I just don't want to have either one of those. And so chronic low-dose therapy of a toxic multinodular goiter is perfectly appropriate. I saw a lady the other day that I've treated for the past 12 years with methimazole, 5 milligrams once a day for a toxic multinodular goiter. We tried to stop it once. She became thyrotoxic right away. So she needs to be on chronic therapy, and that's appropriate. She doesn't want any more definitive therapy. So that's how we use the antithyroid drugs. So what dose do you start with? Methimazole is our preferred agent, and I'll tell you why in a moment, but mainly it's more potent and it can be used once a day, and it has far less side effects than propylthiouracil. So here's a table that we use to tell us what dose should we start with. If the free T4 is 1 to 1.5 times the upper limit of normal, we start with 5 or 10 milligrams, and it can be given once a day. If the free T4 is 1.5 to twofold elevated, 10 to 20 milligrams, 2 to 3 times elevated, 20 to 30. If it's more than 3 times elevated, we go with 20 milligrams twice a day. So that's a good way to start a patient on methimazole. Now, what about propylthiouracil? Why don't we use it, and when do we use it? Well, first of all, it's a lot less potent, so that the doses are 10 times higher than methimazole. It's about 15, methimazole is about 15 times more potent than propylthiouracil. Also, propylthiouracil has a very short half-life, so all doses have to be given 3 times a day. Patient adherence is not as good with propylthiouracil. It's got a lot more side effects. PTU is the 3rd leading cause of drug-induced liver failure. So that's scary, and it can cause a very significant vasculitis, and these don't occur with methimazole. So that's why we try to avoid propylthiouracil. On the other hand, if women who are pregnant take an antithyroid drug, propylthiouracil has significant less teratogenicity than methimazole. And so when women either are diagnosed with Graves' disease during pregnancy, or they become pregnant while having Graves' disease, we switch from methimazole to propylthiouracil for the entire first trimester when organogenesis is occurring, to avoid the teratogenicity of methimazole. And then we switch over in the 2nd and 3rd trimesters back to methimazole, so we avoid some of the liver toxicity. The other time we use propylthiouracil is in people who are allergic to methimazole. So what sort of side effects might we tell people about or look for? Liver function tests can increase. Methimazole can increase the alkaline phosphatase. And this is problematic in some people because Graves' disease raises the alkaline phosphatase. Most people who have hyperthyroidism already have an elevated alkaline phosphatase, but it's bone alkaline phosphatase usually. We usually will not start methimazole if the alk phos is more than 3-fold elevated, but up till then you can start methimazole. Propylthiouracil raises the AST and the ALT instead, and it's, as I said, the third leading cause of drug-induced liver failure. We don't like to start propylthiouracil if people have a 3-fold elevation of AST and ALT, but lower levels are fine. Agranulocytosis is the thing we worry about most. It occurs in 1 out of every 200 people that take these medications. The way it presents is people get a high fever and a sore throat. It can't be predicted. You can't get a CBC and predict that, so we don't monitor the CBC. We tell people, if you get a fever, if you get a sore throat, you need to come in and get a blood test. Now, there was a study that did exit interviews on this large group of people who had Graves' disease to find out what did they remember from what the doctor told them. The thing that came in last place was this: if you get a fever or a sore throat, go get a blood count. So that was the thing people remembered the least. So when does agranulocytosis occur? It doesn't occur with low doses. It's usually methimazole 30 milligrams or more, or propylthiouracil 300 milligrams or more. It's still just 1 out of every 200 people, but it concentrates in people on the higher doses. It almost always happens in the first 30 days. So if you're seeing somebody 3 months later, they're probably not going to get that condition. And it resolves very quickly if you stop the drug. That's why we ask people to go get a CBC. And if they don't, and they maintain that agranulocytosis, it may become permanent, and you're going to have to call your hematology friends to help you out. What about beta blockers? So beta blockers have no effect on the thyroid gland at all. They just affect symptoms, but they affect them right away. And antithyroid medicines take about a month to lower the thyroid hormone levels to normal. So if you give a person methimazole only, they're still going to be symptomatic tonight and tomorrow and all week. If you want to quickly resolve their symptoms, start a beta blocker. We usually use a once-a-day beta blocker, metoprolol or atenolol. Once the thyroid function tests are normal, the beta blocker doesn't really have any function, so stop them at that point. So how do you monitor a patient that you've started on antithyroid drugs? So you need to check their thyroid test 1 month later. And the test that you need to check is a free T4. And if their T3 was high, that's what you need to check. And the reason is that the TSH lags behind. It's been suppressed, and it doesn't recover in the first 4 weeks. And so the first thing you're going to see if your drug is working is the T4 and the T3 normalize, but your TSH may still be low. And if you're only looking at the TSH, you won't realize that it's time to lower that antithyroid drug. So the induction dose, if you will, is much higher than the maintenance dose for antithyroid drugs. Typically, after 1 month or sometimes 2 months, when the T4 and the T3 become normal, we lower the antithyroid drug dose by 25 to 50%. So I gave you the starting doses, and at 1 month, we usually cut that in half if their T4 and T3 are in the normal range. 2 to 3 months later, you want to recheck again, and at this point, the TSH is recovered, so you can start measuring TSH with or without a T4, and just adjust your medication dosage in order to maintain TSH within the reference range. Now, if your patient chooses to have radioactive iodine ablation or surgery, what do we expect as a result? So radioactive iodine for Graves' disease never makes Graves' disease go away. It always causes hypothyroidism. And I showed you that scan a little while ago. Every single cell in the entire gland takes up the radioactive iodine. So when you give somebody radioiodine ablation, it kills the whole gland. So hypothyroidism virtually occurs in just about everyone, just about 100%. I have 80% here because in the other 20%, we don't give enough and it doesn't work and we have to give another dose. But if you give enough, and that's why we tend to overdose the radioiodine, you develop hypothyroidism. That's actually the goal, not a side effect. If you treat somebody with a toxic multinodular goiter or a toxic nodule with radioiodine, because the gland doesn't take up the radioactive iodine all over, it just takes it up in the hot spots, only 50% will get hypothyroidism. Similarly, if you send a person for surgery, and with really big glands, sometimes that's your best choice. About 80 to 100% of people with Graves' disease are going to be hypothyroid because the surgeon's going to take the whole gland out. But they'll only take part of the gland out if it's toxic multinodular goiter or toxic nodule. So again, hypothyroidism only occurs in about 50% after radioiodine or surgery. How do you monitor? It's similar to radioactive iodine. 1 month after, it's similar to antithyroid drugs. So 1 month after radioactive iodine, if you give that, measure a T4 and a T3. Don't look at the TSH because it lags behind. And if the T4 and the T3 are now normal or frankly low, it's time to start levothyroxine replacement. You've made them hypothyroid. If they're still high at 1 month, then recheck 2 to 3 months later with a TSH and a T4. And then you want to just use enough levothyroxine to maintain their TSH within the reference range. So that's the way we approach people with hyperthyroidism, Graves' disease, toxic multinodular goiter, and toxic nodules. And Graves' disease is by far the most common of those. So, okay. Crab is, it has a false negativity of about 5 to 10%. That's why if you really think it's Graves' disease and the TRAB is negative, you should just go ahead and proceed with the radioactive iodine uptake and scan. There are people, though, that the TSI, the thyroid stimulating immunoglobulin, which is an entirely different test, is positive. So your choice there, if your TRAB is negative, but you still think it's Graves' disease, measure a TSI or proceed with a radioactive iodine up. Most of us will do a TSI because it's just a blood test. It'll come back in 2 days. If it's negative also, then you need to proceed with the nuclear medicine studies. Why pretibial myxedema occurs there? I don't know. I don't think anyone's ever really determined that. It's a very distressing disorder. Sometimes it's just a little plaque, but sometimes it's really big. It can also sometimes occur on the elbows, but mainly it occurs on the shins, and I'm not sure why that is. It's a good question, but not a good answer. Okay. So this is a 35-year-old man who has a 1 month history of anterior neck discomfort, difficulty swallowing, fatigue, and insomnia. Vital signs look okay. His thyroid is mildly tender and slightly enlarged. His TSH is undetectable, and his free T4 is elevated. Total T3 is also elevated, so he has overt thyrotoxicosis, and his TRAB is negative. So what's the best test to order now? A radioactive iodine uptake and scan, an ultrasound, barium swallow for the dysphagia, or TPO antibody. So the best test now is going to be a radioactive iodine uptake and scan. Now, there are situations where you don't want to do nuclear medicine studies. This may be someone who is pregnant. This may be someone who's breastfeeding. This may be someone who, for a variety of reasons, doesn't want to do a nuclear medicine study. So other tests that are going to be abnormal in a person that probably has subacute thyroiditis, the SED rate will be very high. And because the gland is inflamed and spilling out its contents, thyroglobulin levels will be high. So you can make a presumptive diagnosis without nuclear medicine studies by measuring a SED rate and a thyroglobulin. So his radioactive iodine uptake was undetectable and no tissue was visualized on the scan. So he's probably got subacute thyroiditis. So what treatment are we going to recommend for somebody now with painful subacute thyroiditis? Methimazole and a beta blocker and an NSAID, potassium iodide and an NSAID, or prednisone and a beta blocker. So the way we're going to approach this patient, the correct answer would be start a beta blocker for his symptoms and an NSAID for the tenderness in his gland. Okay. So now we're talking about these disorders that were on the right side of that slide I showed you a while ago. When the radioactive iodine uptake is low, we have one of these three types of thyroiditis: postpartum, silent, which is identical, it just occurs in somebody that's not been pregnant recently, or subacute thyroiditis, which is painful and has a high SID rate. Now, these three types are collectively called destructive thyroiditis because the gland is inflamed. The thyroid actually stores about 1 to 3 months worth of thyroid hormone in its follicles. So when the gland becomes inflamed and starts spilling out, T4, T3, and thyroglobulin, their precursor, all spill into the circulation from the inflamed gland. But the gland is inflamed, it's not working. So there's no uptake of radioactive iodine. They're not making thyroid hormone. They're just spilling out what they've already made. So this is the clinical course of postpartum, silent, and subacute thyroiditis. Okay, this is going to be the normal range here between these dotted lines. So the gland becomes inflamed, starts breaking apart follicles. T4, T3, and thyroglobulin spill out. So I just list T4 here. The gland spills out its preformed T3. The T4 level in the bloodstream goes up, so the TSH is low. But after about 3 months or less, the gland becomes depleted. It's not making any more thyroid hormone, and it's now spilled out everything it's made, so the T4 becomes low and the TSH becomes high. So there's really a triphasic course. There's a thyrotoxic phase, followed by a hypothyroid phase, and then about 75% of people go back and become euthyroid again. So how do we treat these types of thyroiditis? The first thing is don't use antithyroid drugs. They're not producing thyroid hormone. The antithyroid drugs work by inhibiting thyroid hormone synthesis, and these people are not synthesizing hormones. So you're not going to do any good, and you might be exposing them to some toxicity. During the thyrotoxic phase, we use a beta blocker to treat their symptoms of thyrotoxicosis. And if they have pain, a nonsteroidal anti-inflammatory drug usually works, but in some cases, you need to progress and give them a short course of steroids. Then they're going to get hypothyroid, and it's going to last 3 to 6 months. During that time, if they're having symptoms, it's reasonable to put them on a moderate dose of levothyroxine, like about 75 micrograms daily, and just wait that out. If they're not symptomatic, you don't really have to treat that. The resolution, about 75 or 80% are going to return to normal. If they're one of the 25 to 20% who remain hypothyroid, of course, you're going to have to give them levothyroxine. So the last case is a 78-year-old woman who's had progressive fatigue. She takes lisinopril, atorvastatin, and multivitamins. There's her vital signs: a little bit hypertensive, a little bit tachycardic. Her thyroid is slightly enlarged. It's irregular. It's non-tender. She has thyroid tests drawn. Her TSH is undetectable. Her free T4 is in the reference range. It's at the upper end, but it's in the reference range. And her total T3 is also in the reference range. And her TRAB is negative. So she has a radioactive iodine uptake, and it's 25%. That's read as normal because the normal uptake is 20 to 35%. But her TSH is 0. So this is not normal. That is inappropriately normal uptake, indicating autonomy in the thyroid gland. The thyroid gland is acting without the need for TSH, and the uptake is patchy. So she has a toxic multinodular goiter with what we would call subclinical thyrotoxicosis. So the most likely diagnosis: silent thyroiditis, euthyroid sick, subclinical hyperthyroidism, or lab interference due to biotin. And I put that in here because you know that when we measure hormones in the laboratory, biotin is one of the ingredients they put in the test tube. Biotin makes hormones bind to the matrix so that they can be measured. Multivitamins have a little bit of biotin in them that will not interfere with assays, but some people are taking huge amounts of biotin in hair and nail supplements, and that actually gets into the test tube and interferes with our ability to measure TSH, T4, T3, TRAB, parathyroid hormone, estrogen, and all kinds of hormones, and may interfere with our ability to measure blood levels of some medications. So this lady's taking multivitamins. There's probably not enough biotin, but it's an important question to ask people if they're taking high doses of biotin for their hair and skin, because that'll interfere with labs. It doesn't cause thyroid disease. It just interferes with the lab. And if you stop the biotin for 3 days, it'll resolve. So she has subclinical hyperthyroidism due to a mildly toxic multinodular goiter. So what management are we going to recommend for her? Low dose methimazole, low dose beta blocker, potassium iodide, or observation and monitoring. So this lady, I would recommend treating with low dose methimazole, 5 milligrams once a day. So let's talk about what subclinical thyrotoxicosis is. So our normal range for free T4 here is 0.8 to 1.8, okay? That's a pretty broad range. If you multiply the lower number, the lower end of the normal range by 2, you're still in the normal range. Think about potassium. It goes from 3.5 to 5, okay? That's a very narrow range, but T4 has a pretty wide range. And so a person may be, their normal might be here at 0.9, it might be at 1.2, it might be at 1.5. The idea here is this person used to be right here, and their thyroid is slightly overactive. Their T4 has moved up within the reference range for the population, but that level is high for them, and so their TSH becomes low. So that's what subclinical thyrotoxicosis is, just very mild thyrotoxicosis. But is it harmless? So here was a study out of the New England Journal a number of years ago, and there's been 5 since then that all replicate this. So I'm just going to show you this one. But those 2,000 subjects that they screened for labs, normal people, no symptoms, they measured their TSH, and they had a group that had a low TSH, and they did a 10-year follow-up. They found that people who had a TSH that was below 0.1 had a 3-fold increased risk of developing atrial fibrillation. And even a slight increase, a slight reduction in their TSH was associated with a 60% increase compared to normals. Other studies have looked at mortality. This is a pooled analysis of 52,000 subjects from 10 cohorts. Over 2,100 had subclinical thyrotoxicosis. The total mortality was increased by 24%. Coronary heart mortality increased by 29% and AFib by 68%. So subclinical thyrotoxicosis in older people increases the risk of atrial fibrillation, osteoporosis. I didn't show you that data, but there's an increased risk of fractures and of mortality. And so it's not trivial for an older person to have a low TSH and T4 and T3 that are still in the normal range. So what are the recommendations for management of subclinical thyrotoxicosis? If a person has a TSH that's a little bit low, between 0.1 and 0.5, it's measurable, there's a number, but it's slightly low, you should still consider treatment if they have symptoms of hyperthyroidism, if they're over age 60, if they have cardiovascular disease risk factors, or they have osteoporosis. If their TSH is less than 0.1, you should do the same consideration, just more strongly. Strongly consider treatment for the same indications. So how would we treat these types of thyrotoxicosis if they're just subclinical? Generally, methimazole, 5 or 10 milligrams a day. You may take 10 milligrams to get them to be euthyroid, but you're going to have to reduce to 5 milligrams once you achieve that. 5 is the usual maintenance dose. recheck their TSH in 4 to 8 weeks, and then titrate the dose until the TSH and free T4 are in the reference range. So I wanted to summarize and leave plenty of time for questions. TSH is the overall best test to screen for thyrotoxicosis in any disorder of dysfunction of the thyroid gland. A physical examination and/or a TRAB, a thyrotropin receptor antibody, can identify Graves' disease as the cause. And you don't need to do nuclear medicine studies if your physical exam and/or the TRAB indicate that's the cause. The radioactive iodine uptake and scan, however, are useful for identifying TRAB negative other causes of thyrotoxicosis. A high or normal radioactive iodine uptake in the face of a low TSH, even a normal uptake is not normal. This is hyperthyroidism. We have 3 options: antithyroid medications, radioiodine, or surgery. All are effective. All have their pros and cons. It's a great opportunity for shared decision-making. When people have a low radioactive iodine uptake type of thyrotoxicosis, these are all self-limited. You don't treat them with antithyroid drugs, but you can treat with beta blockers until they resolve. And finally, subclinical thyrotoxicosis does significantly increase the risk of atrial fibrillation, osteoporosis, and mortality after age 60. So we're done. I'll stop here and open up for questions. Yeah.
Question here, group that's, so there's a lot of opportunity for us to manage thyrotoxicosis. Can you think of patients where referring to more urgently the right thing to do? Who do you want to see?
So it's a good question. Who should be referred? And I get asked that quite a bit. First of all, if you think somebody may be on the verge of thyroid storm and just want some support in making that diagnosis, thyroid storm, if it's untreated, has 50% mortality rate. Here we have actually quite a few cases, and our mortality rate is quite low because people get admitted and they get treated pretty aggressively. So if you think a person may have thyroid storm, I think you should refer to endocrinology or admit the patient. The other is people with significant Graves' orbitopathy. We have medicine teprotumumab, which is an monoclonal antibody against the IGF-1 receptor. It very dramatically decreases Graves' orbitopathy. Until this came out, we had prednisone. It didn't work very well, and it had lots of side effects. But the treatment of Graves' orbitopathy is difficult. It's the most distressing thing about having Graves' disease. The thyroid we take care of pretty well. It's the big eyes that are bulging out that get all kinds of problems that are difficult. So I think they need to be referred to either endocrinology or to ophthalmology if they have Graves' orbitopathy. I think if you have any question about toxicity of any of the major drugs, or if they're pregnant. And actually, we take care of pregnant ladies with Graves' disease, but Lynn Barber, who's in our high-risk OB clinic, actually, this is one area that she is just, a star at. She can manage your patient with diabetes or thyrotoxicosis, and she does it all the time. So we often refer people to the high-risk OB clinic to be monitored throughout pregnancy for Graves. Rita.
Is a pituitary cause of thyrotoxicosis? What should be the hints that we should go beyond the TSH to actually look for it?
Could you repeat that? I'm sorry.
So I have a patient where thought maybe she was hyperthyroid, we checked her TSH. I can't remember how long of a delay, but at some point in time we decided to do the full panel, and we think that she has a pituitary cause for her hyperthyroidism, and I don't know when it happened. I don't know if you missed it, or it just didn't fit.
Okay, so you're questioning when you think somebody has thyrotoxicosis but that you're wondering if it might be a pituitary cause, and that's less than 1%. It's important though. So when people have elevated T4 and T3, their TSH, if their pituitary is normal, their TSH ought to be suppressed. So we start thinking about a TSH producing pituitary tumor or a different rare condition called thyroid hormone resistance. when people have thyrotoxicosis, but their TSH is either normal or actually elevated. And so, you know, but you have to make sure that there's no lab interference, like they're not taking biotin or something that's much more common. But if they are, the TSH producing pituitary tumors are usually pretty big, like acromegaly. And so do a visual field exam, ask them about headaches. And if they've got anything that suggests mass effect, then you do an MRI. Or
but have antibody persistence, have all the sort of non-specific fatigue and the sort of non-specific autoimmune symptoms and the thought about the thyroid.
So persistence of antibodies, and we're talking about TRAB now. If they're persisting, the person probably has or is going to get Graves. They're going to have a relapse. But some of those people, and a lot of them actually, have both TRAB and TPO antibodies. In other words, they've got what we just refer to sort of as autoimmune thyroid disease. It's a mixture. And the Hashimoto's antibodies, or the inflammation, is ultimately going to win that battle. They're going to get hypothyroid eventually. So when they have positive antibodies, they're either going to have a relapse of Graves' disease or they're going to get hypothyroid on their own eventually. There's been a lot of work into whether antibodies actually cause symptoms themselves, because you were just talking about someone who may have normal thyroid tests, but they still have symptoms. There was a study that was published, I think it was in the Annals of Internal Medicine a couple of years back, about people who had Hashimoto's thyroiditis. Remember that only 50% of people that have Hashimoto's thyroiditis actually get hypothyroid. The other 50% are euthyroid their entire life. They just have positive antibodies. But they had a group of these people who had big goiters. They were euthyroid. They didn't require thyroid hormone, but they had Hashimoto's thyroiditis. And they had symptoms, and they did thyroidectomies, and actually symptoms improved dramatically. There was no control group. It was just purely they took their thyroids out. So we're not sure what to do with that information. It's not proof positive that we should be taking out people's thyroids just because they're antibody positive. You can reduce both TRAB and TPO antibodies with selenium supplements. That's well shown. And so that's why you'll see people eating Brazil nuts, because they're loaded with selenium, or they'll go to the store and get selenium. And so one way to treat, antibodies is with selenium supplements. But there's a great interest in whether we should be taking people's thyroids out if they have persistent symptoms and positive antibodies, but they're euthyroid. A lot of patients refer themselves to our surgery or to us, to ask that question. I just don't think there's strong enough data to start taking out everybody's thyroid gland. A lot of those people have very nonspecific complaints, and I'm really concerned are going to still be there after their thyroid's out. Yeah. Oh.
Are there future pregnancy issues having these thyroid meaning like preservation of that? Not pregnancy.
So the question is, are there pregnancy issues in somebody that's had radioactive iodine? So the amount of radiation actually is quite low, and it gets concentrated in the thyroid gland. And so it does, the ovaries have some exposure because we excrete radioactive iodine in the urine, but it's at a very slow rate. It takes about a month. We've put Geiger counters over people's thyroid just to see how long they stay radioactive. It's like a month. They still have radioactive iodine. So it leaches out very slowly. So there's not been any issues ever identified with ability to have, fertility or with any kind of birth defects in people that have had radioactive iodine. We ask people not to get pregnant for 6 months after we give radioactive iodine, because they've been hyper, and they become hypo. Their thyroid function tests are fluctuating, and we know that's not optimal for a healthy pregnancy. But it's not because of the radiation, it's because of their fluctuating thyroid tests. So they're actually, because the treatment course with antithyroid drugs is often 18 to 24 months. Or sometimes young women say, we were hoping to have a pregnancy this year. I don't want to wait 2 years. And that's one of the situations where people say, let me have radioactive iodine or surgery now. you know? So, and so we are confident that radioactive ion doesn't affect fertility or subsequent pregnancies. Katie?
Along the same lines, how do you generally counsel patients about their radioactive iodine? Like, you're radioactive and they terrifying, then I don't know.
Well, when I was a fellow, that was what we treated everyone with. I mean, it was like the favored way. And there were surveys in the United States, and that was highly favored in the United States. Now, antithyroid drugs are by far and away the most common way we go. I tell people it will make you hypothyroid. We are not aware of any, and there's a little addendum to what I'm gonna say. We're not aware of any absolutely well-known risk of any malignancies occurring after radioactive iodine for Graves' disease, nor with the higher doses that we give to treat thyroid cancer on a first dose. But when you've given multiple doses for thyroid cancer, we do start seeing leukemia, lymphoma. So the people at the National Cancer Institute did actually this enormous study recently where they looked at a large number of people who had gotten radioactive iodine, and there was an increase in breast cancer. And it was the best study done so far. It's still controversial, so I can't get away from that. You know, it's a very small increase, but it was there. So if people ask me, do I have any risk of cancer? I really can't say no. I can say there seems to be a small increased risk of breast cancer. And I think that's newer data that contradicts older data, but the study was much bigger and much better than one we've ever had. The biggest side effect we get or risk is dry mouth, because the salivary glands take up radioactive iodine. And so it's interesting that cavities are more common in people that have had radioactive iodine because they don't make as much saliva, and there's antibodies in saliva. So we try to give them like cough drops or something, or have them suck on lemons or chew gum to try to get the radioactive iodine out of their salivary glands. So they can get dry mouth, and that's probably the most common untoward effect that we see.
Two questions. First one, do you recommend checking TSH in all patients newly diagnosed with osteoporosis?
So do you recommend TSH in all patients with newly diagnosed thyrotoxicosis? Yes. With osteoporosis? Yes. I'm sorry. Yes, and that's recommended by the bone experts as well. In the osteoporosis field, if you check people for vitamin D, TSH, celiac disease, and a basic metabolic panel, 1/3 of women will have a significant abnormality on one of those, and 2/3 of men will. So it's definitely worth looking for secondary causes, and it's easy to treat. So hyperthyroidism, hyperparathyroidism, and Cushing syndrome or steroids, when you stop the offending agent, their bone density increases as much as it would if you put them on an osteoporosis medication. Like when we do parathyroid surgery, we don't put people on meds. Their bone density goes up. It's true with hyperthyroidism also. So it's a good diagnosis to make. It saves a lot of other problems. So I do recommend a TSH.
Then the second question is, this is my own radioactive iodine uptake and scan are all set together. Uptake and scan. Are they separate? And if they're separate, can we skip the scan? So
Yes, so they usually do them together, and in Epic they're actually ordered together. But if the radioiodine uptake is just a small amount of radioactive iodine, the scan is done with technetium. Okay, if the radioiodine uptake is zero, they don't need to give the technetium. They don't need to do the scan. It'll never show up. So it's a wasted step, and it's another $150. So if you I have actually written that in orders before. I don't know if they read them or listened to them, but if the uptake is low, don't do the scan, because they are separate. They are separate tests. The scan is only useful when the uptake is normal or high, so that you can see the morphology of the thyroid gland.
Do we know in people over age 60 with the subclinical hyperthyroidism, whether treating thimerosal to decrease the doses of
So that's a very key question. You know, does treating with thimerosal, reduce those risks that we talked about. That's never been studied for mortality or for atrial fibrillation, but for osteoporosis or bone density, it has. So not for fractures, but bone density increases. So of those endpoints we just talked about, no for AFib, no for mortality, no for fractures, but yes, for bone density, it does improve. So that's at least a surrogate, indicator that maybe we're doing some benefit. So yeah, the treatment is like, oh, okay, well, we see these risks, we've got to treat, and you're right, but maybe we're not doing any good. I think we are, but I don't know that. Robert.
You mentioned it earlier that, treating with methimazole, people go into remission from rape. I assume that means that the thyroid antibody is negative, at that point. Methimazole is not causing it, right? It's just, you treat them until the body starts taking them.
So that's been a debate for a long time. Do they just spontaneously go into remission, or does methimazole actually cause it? So methimazole actually has more effect than inhibiting thyroid hormone synthesis. It's highly concentrated in the thyroid gland. The methimazole, the intrathyroidal half-life of methimazole is about 36 hours. So if you're giving it daily, it just sort of builds up. And it's lymphocytolytic. So in cultures of lymphocytes, if you add methimazole, the lymphocytes die. So it's thought that maybe it does affect the autoimmune response. Interestingly enough, the site of the anti-thyroid antibodies is within the thyroid gland itself. So it's the lymphocytes in the thyroid gland that are making the trap. And so by killing those, methimazole probably does contribute, to some degree to the spontaneous remission. We do see people that have really mild, Graves' disease. They're young, they don't want to be treated, and it's gone away spontaneously. So there's no question that Graves' disease can spontaneously remit. But I think methimazole adds a boost to that. All right, thank you. Yeah, I hope that answered everybody's question.